Thank you very much. Thanks for the invite, Marie. It's a particularly tough crowd. I am like you've heard, I'm a surgeon, so I spend my time on the other side of the curtain to you guys. But when we do these things, it's critically important that the sedation goes well. If it doesn't go well, everything is bad. So this is a very important topic. So I've got a few disclosures. I'm by no means a pain specialist. I manage neck and lower back problems that cause pain. I work with my hands, and I do my best work when the patient's sleeping and I'm fixing. But I see people with neck and back problems, and because they have to pay to see you, they come for a reason. But out of that cohort, only 12% of those patients need an operation, but they've all got pain. So I would much rather operate everyone. That would be a lot easier. But there's 88% of the patients that you see that has got pain that don't need an operation. So you need to make a plan of it. So out of necessity, I became a non-surgical pain practitioner as well. I only perform some of the procedures that I'll speak about today. There is limited evidence for some of these procedures. I, on purpose, excluded implantable neural modulators for two reasons. First, it's a surgical procedure, not a pain procedure. And in my experience, most patients that I see with these devices in it has got some other mechanical reason why they've got pain in the first place and they actually need an operation. And I also excluded vertebral augmentation, kyphoplasties and vertebroplasties, because these things are being performed by pain practitioners, but I think it's extremely dangerous because the complications of these procedures are pretty severe. And I don't think you should be performing a procedure of which you can't fix the complication. So we'll speak a bit about the epidemiology, what causes back and neck problems, what are the pain generators, and then what are the treatment options available. And then we'll speak a bit about pain generated directed interventions, what are the options. And then now I would like to spend some time on the evidence because I've got a bit of a bugbear with some of these things in that I'll get that out the way soon or early in the piece. These procedures are being abused. It's being done left, right, and center. You only need a medical degree to be able to perform it. You don't need to be a specialist, and you don't need any real formal training, or it's completely unregulated as well. Medical aids are paying for these things, whether you're a super specialist or a GP, doesn't matter. And it's the same value, monetary value. So there's a lot of so-called pain clinics where you go and these things get offered, but these patients don't really have a treatment plan in general. Okay. And then we'll speak a bit about what we need when we do these things from the anesthetist. All right, so lower back problems are common. It's a good line of business to be in because we pretty much all get it. It's the second most common cause to visit the GP, which is surprising. It's staggering amounts of money that's being spent on it. But 90% of the pain will be gone in a year's time. 20% of patients develop a chronic type pain syndrome, which pain lasting more than 12 weeks. And this is what we're trying to prevent because those patients are a lot more difficult to treat. So the message is we all get it, but it's got a very good prognosis. Spinal conditions in general has got a terrible stigma involved with it. Patients are, when I see a patient, I can see this, okay, he's scared now. This is terrible. But it's got an inherently great prognosis. Most people come right. And these days, even the ones that don't come right, that need an operation, they do incredibly well. It's not like 20 years ago where spinal surgery was a salvage procedure in general. Nowadays, we can, when we operate people, we've got normality in mind. We want 3 months' time, you must be a normal person. That's what we're aiming for. So pretty much every structure in the spine can be a pain generator. It can be muscular, it can be the intervertebral disc, it can be the facet joints, it can be the SI joint, it can be mechanical instabilities, and then of course the neurological structures, either nerve roots or the coda equina that causes pain. Neck pain is slightly less common than lower back problems because your neck only needs to carry your head around. But it's pretty much the same disease. Neck problems and lower back problems are the same illness. It's more common in women. And like I say, it's in generally a slightly better prognosis. But if you have spinal stenosis or cervical spinal stenosis, it's at cord level, so the morbidity is more. And that's why it's important to pick these things up early to fix it. So in general, the treatment options are conservative management. Of course, my Cuban colleague in Kimberley, when I was an intern, he said conservative treatment is also treatment. And but that was out of laziness most of the time. So most people get treated conservatively, and they do very well and recover by themselves. Then there's these interventional pain procedures that we'll discuss now, and then of course surgical management. The vast majority of patients will, if you just allow some time, they will get better. And it's very important to look at these patients holistically and look at what is it that they do, or what causes the pain, and address that. Analgesia plays a very limited role. Bit of NSAIDs, some, particularly the general practitioners, like using oral steroids in the short term. It works quite well. Muscle relaxants, and importantly, stay away from the opioids. There's a massive problem in the States with oxycodone and these things that you guys know better than me. But opioids plays no role in the management of back pain. We use a bit of it post-operatively for the first week or two, and that's it. It's well proven that being fat doesn't cause back problems, but if you're overweight, it makes the back problem more symptomatic. So weight loss helps, but in general, these people have got pain, so they struggle to exercise, so they struggle to lose weight, so it's a problem. Physiotherapy, very helpful. And then in the old days, they put you in bed for a long time, and they even put you in traction. The older guys would remember, but that doesn't help. So physio, they do spasm reliefs, some postural advice. Very important is the muscle strengthening, core strengthening, and these things. So surgical management in general, you can do decompressions where you relieve pressure on the compromised nerves, and that takes the leg pain away or takes the claudication symptoms away. You can do a discectomy. That's for commonly referred to as slip disc. You take the disc out and under the nerve root, and the pain is gone. If most of the problem is back pain, and there's also a neurological component, or there's an instability, a fusion is a very good option. It's a common misconception that we do fusions for back pain. We don't. I have never, not once, fused a patient for back pain. The reason for that is because they do so well with conservative management. We fuse patients that have got neurological symptoms that has also got significant back pain or some form of instability. They get fusions. So decompressions, simple laminotomies, laminectomies, and to relieve compression. Discectomies, very commonly performed. In the old days, they cut you open, large incisions to take the disc out and do a laminectomy to get it out. These days, we've got very fancy, small, minimally invasive procedures that you can do with patients often go home the same day, at the most the next day. Particularly now, exciting new field is endoscopic surgery, which is sort of percutaneously where we use arthroscopes to go in. And these patients it's probably you guys going to get more and more exposure to them because we do it awake. And you need a very good sedation for that. So that's a picture of a microscope. This is an endoscopic discectomy. So when you talk fusions, like I spoke about now, it's for patients with neurological problems, with also significant back pain and instability and oftentimes deformity. I do a lot of adult spinal deformity, and these patients, obviously, you can't temporarily make someone straight. You need to fuse them in that position. So in the old days, they did non-instrumented fusions, did terribly badly, and the patients all went into a deformity because of the surgery. Then we started doing posterolateral instrumented fusions, which is sort of fallen by the wayside now. Still being performed, but it's not the best thing. And then there's what we do these days is interbody fusion. So, and there's various options how you can do this. Also, common misconception that your back is at the back. It's not. Your back is in the middle of your body. So it's fairly simple to approach it either from the front or from the side or obliquely. And that's I do a lot of my work anteriorly. Patients just do a lot better. And then you've got a recipe and you put them all together and you can fix complex problems with all these different procedures. In the neck, sort of same type of thing. The workhorse is a ACDF, so anterior decompression and fusion. You can fix most things with that. Posterior surgery, the patients don't, they often get wound problems and a very painful procedure, but also often done for the right reasons. Yet again, neck pain, even more so than the back pain, is never an indication. Neck pain does very well with conservative management, but if there's neurological symptoms, then surgery comes into play. All right, so the crux of the matter, the interventional pain procedures it's a group of interventions, and it should be aimed at a specific pain generator. So in order to identify the pain generator, you need a diagnosis. And then these procedures then form a part of your treatment plan. And that is my bugbear, because most of these rhizotomies and facet blocks and things are done without a general treatment plan. It's just being done. Patient doesn't have a firm diagnosis. We don't know where you're going. We don't know what the prognosis. Yeah. So these things are useful. In my hands, particularly diagnostic. You take a patient's history, you get a very good idea what's the story. You examine him, okay, it probably is that. Then we've got these very fancy scans and things these days, MRIs and CT scans and all that. It takes all the guesswork out of the whole thing. You're very sure what the pain generator is. But sometimes you're a little bit uncertain about what's happening at the adjacent level. Is this really what's causing? Is there instability causing part of this? So then these things it's with these blocks and nerve blocks and things, it's then fairly simple to figure out exactly what the problem is. It just makes your yield of surgery so much better, because you can do a beautiful operation, but your diagnosis is wrong and the patient doesn't do well. Of course, it can be therapeutic, and then sort of a perverse incentive from my side, I often use it as a buying time type of thing. If I'm not sure about the patient, you're not like sure what's happening upstairs, and patients maybe not 100% ready for a procedure, and also you want to optimize comorbidities and their bone health and so you buy some, you make them better for a while we're waiting for the best time for surgery. So, like we said earlier, pretty much all back pain and neck pain will get better if you just give it enough time. So these things are useful to buy some time. Patient then will get better. You can understand if a patient sits there in front of you and he's in serious pain. Most of these people, my previous partner said, you haven't had proper pain until you've had proper back pain. So these patients got a lot of pain. Now you sit and you do the story and you check the scans and tell the guy, great news, you don't need an operation. Sharp, there's a door, pay as you leave, please. They're not happy with that. He's still got pain. You need to do something for the guy. So that's where these things are very useful. Okay, like I said, these patients need a diagnosis and a treatment plan. Because I've done my fair share I've seen quite a few patients in the last while, patients that had rhizotomies somewhere else that's actually got a fracture, or there's a metastasis, or even worse, infections and things. It's not good. So the patient hasn't been worked up, but he's had procedures. Okay, so you need to target a specific pain generator. So what you can target is either the facet joint, the intervertebral disc, or nerve roots. So the toolbox, what we got? We've got facet joint interventions, there's epidural injections, there's sacroiliac joint interventions, and then intradiscal therapies. We spoke earlier about the vertebral augmentation, it's rather not talk about, and then the implantable devices. So the facet joint. The facet joint gets innervated by the medial branch, and so the joint has got a pain or a nervous supply. And if you can interrupt that nervous supply, you make the pain better. So you can either do a medial branch block, or you can do a facet block, or you can do rhizotomies. Rhizotomies is sort of a misnomer bucket term for a whole bunch of different procedures. So the medial branch block, you inject some local anesthetic with or plus or minus some corticosteroids around the medial branch. You can do it, I do it fluoroscopy guided, but there are now quite nicely ultrasound sonar guided techniques as well. This for me is a very useful diagnostic test. Facet block, you put the needle inside the joint, which is easier said than done. It's a very small joint. It's got a sort of intricate anatomy, and oftentimes it's arthritic as well, so the joint space is narrow, so it's actually quite not that easy to get in there. And also, once you're in there, there's a very limited volume of the joint to actually get some medicine in. So if we look at the evidence for this, there is none. For facet blocks, they're really not good evidence. Okay, so rhizotomies is a bucket term for disrupting this medial branch block. You can either cut it off, or burn it off, or temporarily change the way or modulate the way it's transferring the nerve signals. So it's either through a radiofrequency ablation, or you can do it these days with endoscopes as well, where you actually go cut the nerve off. This is slightly controversial because there is a feeling that if you cut the nerve supply of a joint, whether it's your ankle or your knee or whatever, it can cause a Charcot joint. We'll see. There is some research about that now. So with a radiofrequency ablation, we target that medial branch and you disrupt the nerve's conduction. Various techniques, but yet again, it is very, very operator dependent. If your probe is in the wrong place, it's not going to work. So these things are controversial, and there's terrible. The research in general is not good because it's operator dependable. It's the only way of really doing good research on them is to take one single guy's way that he does it, or take all his results. And in general, these guys are then very good at it, so they get very good outcomes. Whereas the other oaks running around, needles in the wrong place, so they don't get such good outcomes. Now everyone says, but rhizotomies doesn't work. So it's a very complex thing. There is conflicting evidence for this. In general, I was actually surprised now when I had a look again at there's actually pretty good evidence for rhizotomies, and it's fairly positive. Conflicting yet again, but there's some really, really good evidence. Particularly, I like this is a good journal, the Journal of Spine Surgery. That's a high impact journal, and this is some good results. So that's for facet joints. When we go to the intervertebral disc, what can cause problems there is either annular tear, so tear in the outer portion of the disc bulges and herniations, and then lumbar disc degeneration, which is very, very, well, we all have it, various degrees. So the options to target this is with an epidural cortisone injection. There's intradiscal electrothermal therapy and radiofrequency posterior annuloplasty, which both of them, we'll chat about them briefly, but it's very controversial. And then discograms. So epidural cortisone injection, you can either access the epidural space through the caudal approach or the interlaminar approach. The caudal is particularly easy and very safe, and you get a higher concentration of your anti-inflammatory medication right where you want it. So it's useful. Pretty good evidence for that. Not so great for the interlaminar, for the higher up problems. And I was once at the pain congress thing where a guy that he's a GP, he's a GP, and he was describing his great results of doing cervical epidurals. I'm get nervous when I work there. Now you sticking needles straight to a guy's spinal cord, and it's just, but you don't know if you don't know. That's so this intradiscal electrotherapy therapy. They put a probe inside the disc itself and then heat it up. Don't know exactly how it works, but probably the nerve fibers are being coagulated and annular fissures as well. For annular tears, there's also a technique described where you put your probe right at the annular tear and then you heat it up and it coagulates the annular tear. Very limited research and not being supported. Discogram is a useful diagnostic test, also controversial because there were some papers early on that said it leads to disc degeneration, but that's been refuted in the last while. It's useful for me when I'm not sure whether I should include the level above where I think the index problem is. So how you do it, the patient must be awake, and you put the needle inside the disc itself and you inject contrast. If the patient says, yeah, that's the pain I always feel, that's a positive test. And if you do the one adjacent to it and he says, no, that's fine, then it's very positive. And if you then afterwards we do a CT scan so you can actually see what the disc looks like. Well, that's useful. A positive discogram is then highly indicative that it probably is the pain generator, and you should get a good outcome with surgery at that level. So that discograms are supported by the literature. Nerve roots. So nerve root problems. It's being caused by disc herniation or sequestration or annular tear under the root or whatever, and it causes leg pain. And according to which nerve it is, you can very accurately say which nerve is being irritated. And you can target them either with an epidural cortisone injection or with a root block or with a dorsal root ganglion radiofrequency lesion, sort of a rhizotomy of the dorsal root ganglion. These procedures are all fairly well supported by the literature. So when you do a dorsal root ganglion radiofrequency lesion, you put your probe right there where the dorsal root ganglion is, and you send some radiofrequency energy through it, and it modulates the way that the nerve root transmits the signals, and the patient's leg pain then slightly better. So the idea is that about 85% of all disc lesions will resolve by itself. The disc bulge or herniation, whatever, pulls back slowly back in, and the inflammation being caused by the nucleus pulposus being migrating to the nerve structure goes away after about 7 to 10 days, and the patient actually starts feeling better. So you buy some time while nature takes its course. And it's well supported by the literature, like I said. The SI joint, it's a big joint where your spine joins your pelvis. It's an underdiagnosed pain generator, difficult to diagnose. It's a clinical diagnosis and very, very difficult to figure out. I also sometimes think it's overdiagnosed because once you start thinking about it, then everything starts looking like a SI joint. But particularly in patients where they've had a long fusion to the sacrum, they often get SI joint problems. Good literature to say that it's actually fused by around 50 years of age, but so it shouldn't then be a pain generator after that anymore. And of course, it's associated with seronegative spondyloarthropathies. So you can either inject some cortisone into it, or you can do a radiofrequency lesion of it, of its nerve supply. It's difficult to get into that joint, really hard. CT guided probably the best, but just with fluoroscopy it's difficult. And then once you're in there, there's very little volume. So if you put a contrast in to see that you're in, there's actually no space for the medicine. So the radiofrequency lesions are slightly dodgy because 70% of the nerve supply of the SI joint is from the front, which you can't access with your probes. Okay, so this is not a recent article, but I thought these guys did really good work. They had a look at all these procedures, what's the evidence for it, what's against it, and they summarized it very nicely. So like we said earlier, facet blocks, it's a bit dodgy. There's not that great evidence for it. Medial branch blocks, there's some papers that's for it, some against it, sort of middle of the road. Rhizotomy is surprisingly good evidence, surprisingly. So I think it should, in general, the controversy behind the thing should maybe not be such a factor anymore. Epidural cortisone injection, really good procedure. Nerve root blocks, yet again, good procedure for the right indications. SI joint rhizotomies, not so great. Injections, not so great. The intradiscal therapy is really bad evidence for that. So in summary, there's good evidence for doing epidurals, rhizotomies, and root blocks. And for the rest, not so great. Okay. So when we do these things, we've got some expectations. There's nothing worse than putting the needles with one hand and holding the patient down with the other. That's really not fun. And it can be really bad experience for the patient as well. And a very, very large part of this management is this pain patient is the sedation and the whole experience. Because they are difficult to sedate, because they sort of wound up, they've got a lot of pain, they're anxious, they are worried about this whole thing. So you guys are critically important in the management of this. So the first things first is you need an awake patient. If you're sticking needles to neural structures, okay, if you miss and you hit a neural structure, you're going to injure that structure. And even worse, if you inject stuff into a nerve root, that nerve root is buggered. It's klar. And if that happens and the patient was sleeping, you've got no defense. That's it. So the fact that the patient is awake is your final safety net in this whole thing. Because if the patient is pain-free, so he's comfortable, you stick him, but no one can sedate you such or can be so pain-free that a nerve root that they won't feel that pain. If you stick a needle into the nerve root in an awake patient, they jump off the table. So that you need an awake patient. It's for safety's sake. All right, so how to achieve this is the patient must understand. We go through, I'm lucky that I've got 2 GPs that work in my practice. They take all the consent, so they get to spend a lot of time talking the patient through this. And then even after all this, the patient arrives and they say, yeah, I didn't know I was going to I want to sleep. I want to be out. So you need to inform patient. And then you need a nice environment. Marie knows my theater is actually a fridge. It is really cold in there. So luckily the radiographer remembers and they turn the temperature up before the pain procedures because it needs to be nice in there and it needs to be like a quiet and rustig. No people kicking over buckets or loud music playing. And then the positioning is uncomfortable. I've got a seriously expensive, beautiful theater bed that's built for my comfort, not the patient's. So you need to, particularly the ladies, it's not a lacquer way to lie, so you need to sort that out. And look after the patient's decency. The oak's awake, man, so cover him, the ladies, lie there without clothes on. And then you need decent analgesia. The sedation, the fact that the guy is not completely with us is one thing, but he needs to be pain-free. That's the important part. But not so pain-free that he doesn't know that you're sticking in the nerve. Okay. That's where the trick comes in. Okay. So the short thing is follow Marie's recipe. Her recipe works. I've worked with a lot of people that does this for me, and Marie does it the best. So, all right, thanks.